Good morning, one and all. I am Dr. Atul. My topic is intrastromal voriconazole as a successful adjunctive treatment approach for recalcitrant deep fungal keratitis. It is not working. Excuse me. Pardon?
Slides not moving.
Yeah, not functioning.
Right. Please.
Can you restart the timer, please? So my topic is intrastromal voriconazole as successful adjunctive treatment approach for recalcitrant deep fungal keratitis. Fungal corneal ulcers are accountable for almost half of the cases of culture-positive infections in developing countries. In view of delayed presentation and non-availability of antifungal drugs leads to complications like corneal descemetocele, staphyloma, endophthalmitis, melting perforation, and finally blindness. The treatment of fungal keratitis is challenging due to quite a few limitations like suboptimal corneal penetration, ocular surface toxicity, and limited spectrum. Surgical modalities like therapeutic PK are frequently required for deep fungal keratitis with limited outcome. Newer antifungal agents such as voriconazole, posaconazole, and capsofungin have a good safety profile and better corneal penetration compared to conventional natamycin. Targeted drug delivery can achieve satisfactory drug concentration at the site of infection, and in these intrastromal injection shows promising results. So aim of my study was to assess efficacy of intrastromal voriconazole in the treatment of fungal keratitis not responding to conventional treatment of topical and systemic antifungal drugs. Study was conducted at tertiary eye care centers of North India from January 22 to October 22. Patients with smear and culture positive deep fungal keratitis not responding to topical and systemic antifungal drugs, including 5% natamycin and 1% voriconazole for a period of 2 weeks were involved. Patients with scleral involvement, any perforation, patients with signs of endophthalmitis, allergic to voriconazole, and one-eyed patient were excluded from the study. All patients underwent Snellen's visual acuity testing as well as slit lamp biomicroscopy examination. Size of the ulcer, size of infiltrates, any satellite lesion, any pigmented lesion, and height of hypopyon were noted. Area of the ulcer was calculated from its maximum diameter and the dimension perpendicular to the maximum diameter. The depth of corneal involvement in all cases was extended up to or deeper than mid-stroma. AIOC2024 was done to evaluate the depth of corneal ulcer, and B-scan was done to rule out the posterior segment pathology such as endophthalmitis. Diagnosis of fungal keratitis was made based on clinical evaluation and positive smear as well as culture of the fungus. So total 18 eyes of 18 patients were evaluated, 13 were male. Mean age of presentation was 51 years. Most common cause was vegetative trauma in half of the cases. Mean initial BCVA in logMAR was 0.94. All patients had anterior 1/3 to anterior 2/3 involvement of corneal stroma. Mean size of corneal ulcer was 4.44 millimeter. Mean depth of corneal ulcer measured by AIOC2024 was 306.5 micron. 13 patients had satellite lesion while 3 patients had hypopyon. 3 out of 18 patients had centrally located ulcer while 9 patients had paracentral and 6 patients had peripherally located ulcer. Most common organism isolated was fusarium followed by aspergillus. So out of 18 patients, 17 were successfully treated with ISV, 6 patients required single injection, 7 patients had to take 2 injections, and 5 patients had to, they improved after 3 injections of ISV. Mean number of injections was 1.94. Mean resolution time was 18.5 days, and 13 patients with satellite lesion and 3 patients with hypopyon resolved completely after ISV. These are few of my patients who improved very well after intrastromal voriconazole injections. This is KOH mount showing filamentous fungi. None of the currently available antifungal drugs such as voriconazole are able to manage deep fungal keratitis because of suboptimal penetration of the drug, ocular surface toxicity, as well as limited spectrum of drug. So voriconazole has advantage of good safety profile and has been shown to be effective against fusarium as well as aspergillus species. Voriconazole has been shown to have better outcomes due to lower mean inhibitory concentration against filamentous fungi. The size of the ulcer and height of hypopyon at the initial presentation were significantly affected treatment outcome. Patients who presented early required lesser number of injection, while patients with smaller size of ulcer and infiltrate needed lesser number of injection. But statistical correlation could not be made out. In our study, there was 100% success rate in corneal healing after ISV, and the mean healing time was much lesser, 18.5% compared to the previous study. Machinery et al., they reported ISV as an ineffective approach in treatment of filamentous fungal keratitis, while a more randomized clinical trial also concluded that intrastromal injection did not offer any beneficial role in over topical. In our study, repeated intrastromal injections of voriconazole have also been tolerated without any long-term toxicity. Mean time duration between onset and presentation was 10.8 days. Large clinical trials and large sample size with long-term follow-up are warranted. So concluding, target intrastromal voriconazole injection 50 microgram per 0.1 ml appears to be feasible and effective adjunctive treatment approach in treating recalcitrant deep fungal keratitis not responding to topical and systemic antifungal drugs. Though some may require repeated injections, but it reduces the risk of therapeutic
stop
decay.
time out.
Thank you.
Okay, thank you, Atul. A beautiful study. After how much time the second injection was given once it did not respond?
Sir, if there is no response to the treatment given, then we waited for 3 to 7 days, and after 7 days, if still there is no response, then we give second injection. And
On average, you repeated it on 7th day?
7th day. Yes, sir. Not before that, sir.
And all of them were proven positive microbiologically?
Yes, sir. Proven positive, either smear or culture.
What percentage was the fusarium?
Fusarium was 17 out of 18, sir.
That's
in Northeast, Fusarium is more common.
Yes, it's almost throughout India, this pattern now.
Sir.
Thank you. Thank you very
so
much.
much.